April Kyle, and I am a customer owner in our healthcare system in Anchorage, Alaska. Doug and I are going to talk today about how we approach our most complex customers in our healthcare system. But before we do that, I want to give you a little bit of context as to what Southcentral Foundation is about, who we are, where we come from, before we talk about that specifically. So our first slide is our so what slide. We're asked to speak at conferences throughout the year, and I always think showing data first is better than showing data at the end. So we have reimagined what a healthcare system can look like. It's a customer-owned, customer-driven healthcare system. I am Alaska Native Athabascan, so I'm a customer in our system. And as we have rethought healthcare to be customer-driven and relationship-focused, we've recognized in our system decreases in hospitalization, ER utilization, specialty visits, and we've moved the mark on our HEDIS measures for our populations in ways that we are really proud of. Our vision is a Native community that enjoys physical, mental, emotional, and spiritual wellness. We believe in the idea that every one of us has this multidimensional wellness within us right now in this moment, that there's a story behind all of our eyes. I'm the Vice President of Behavioral Services. Doug is the Vice President of Medical Services, and we see our work as being combined. So we don't do behavioral health in some building for some people over there, but rather it's really integrated, and you're going to hear more about that. Our mission, how we do it, is by working together. We believe in co-creation, shared responsibility, and partnership, and that happens at a macro level. So how we as a healthcare system create relationship with a community, ask the community to drive what healthcare can be. It happens at a micro level with each of us and our teams and how we interact with individuals and families every day in the care that we deliver. We have 3 core values. The first is shared responsibility, commitment to quality, and the third is family wellness, which I haven't mentioned. We value that in our communities, families are really the heart of communities, and we think that Western medicine has focused far too much on physical wellness of individuals, and so we design our programming to be about multidimensional wellness of individuals, families, and communities, and we think when you imagine that, it changes what healthcare can be. You've heard me use the word customer owner. We don't say patient, we don't say member, we don't say client. That helps us rethink our relationship as a healthcare system with the owners of the system itself, and it helps us rethink, as Alaska Native people, our relationship to the system and our relationship to our own journey to wellness and how we are really in the driver's seat, how we are really the owners. The most important word is owner. If you work for us, you'll try to say patient, and we'll nudge you and say customer owner. And in 3 or 4 months' time, customer owner becomes the natural lingo that you think of in describing our community. We have a set of operational principles. I won't go through these, but I'll say they came to us from our customer owners. We asked them, what do you want out of a healthcare system? And we use these principles as our drivers of how we design what we do. Last piece of introduction I'll give is that we think in healthcare, the main product, what we're about, isn't diagnosis and treatment plans and prescriptions and all those types of things. We think the primary product that we deliver is relationship. And the quality of that relationship becomes what moves us towards that journey to wellness. And we work on that from all types of perspectives, rethinking relationships within teams, relationships between us and community, rethinking relationships within hierarchy and removing hierarchy, and creating interdisciplinary work.
So let's hit a couple of other sacred cows while we're at it. So we are a medical system. We provide clinical care. We're actually vertically integrated. We have a partner who, between us, we run a hospital. So we're everything from community-based all the way through a NICU, ICU, CCU, the whole 9 yards. We're essentially a ACO, a vertically integrated system. But we've recreated over 20 years' time completely this system on the premises that April just described to you. And those operational principles really are what we use as the scoring card for all new ideas. So everyone in the system, whether it's executives, frontline staff, or consumers, can use those and say, I want to do this, and if it aligns, we want to do it, and if it doesn't align, then we don't want to do it. At any given time in our system, we have 75 major reinvention products and projects underway, and that's despite 20 years of already existing evolution. And the outcomes, as April said, have been absolutely remarkable and astounding. So just a couple other things. We don't like the word patient, although we won't castigate you too badly if you use it, but we really hate the word compliant. And the issue of non-compliant and non-adherent is just an arrogant, professional-centric, facility-centric institution-centric way of doing things. The idea that you must come to our space in our exam room in order to interact with us is also professional institution-centric, and it's time to abolish that. In today's society, we communicate through smartphones and lots of other ways. So in our system, you connect with this integrated care team, which is a provider, case manager, case management support, and CMA as your main primary care team, but fully integrated with them are behaviorists, pharmacists, dietitian, midwives, and a clinical social worker. And all of those people are available to you same day, guaranteed through whatever modality you want. So in person, phone, text, email, to all of those people, each of whom know you on a first name basis. Does that make sense? And we've sustained that for 18 straight years. Full open access relationship. If you're going to do a relationship, you have to remove all barriers to care: physical, time, attitude, language, gender, all of those types of things. The physical environment is very different. We could do a whole hours-long talk on the physical space, and we think this is extremely important. We're obsessed with the physical environment because if you get it wrong, you can't do the functional things that your team needs to be doing. So we've de-officed all management. We've eliminated all nurses' stations. We've demedicalized most of our environments. And there is no separate place that any of these people go. In our entire 175,000 square foot big primary care center, there's not one single private office for anybody, no matter their title or their function. When it comes to quality and how we actually approach this business, especially of the most complex people, which April's going to go into in more detail in a few minutes, there's some things that are very fundamental to how we think and how we do quality and safety. And so, by the way, the number one safety contribution is to decrease hospitalizations by 50%. If hospitals are unsafe, keep them out unless they have to be there. Then make them as safe as possible. We believe hugely in complex adaptive system theory. We are very good at Lean and Six Sigma, but that only applies to about 1/3 of modern medicine does. If the patient or the customer owner is passive, then it can be a manufacturing process. But in 2/3 to 3/4 of what we do in healthcare, the patient is active. And in that environment, it's like supporting a bird in flight rather than a passive object on a table. And that means complex adaptive system theory makes sense, and that Six Sigma and Lean probably really don't make a whole lot of sense. And this is very different for most healthcare systems to begin to understand. There's a whole science behind this, and there's a lot of proven outcomes around this. The idea of tight, loose, tight sometimes helps people understand that, where we're very obsessive about the philosophy up at the high level, what is it we're trying to accomplish, and we're very high on accountability for the actual outcomes. That's the tight at the bottom. But the middle, the loose, how you actually accomplish that in your teams and in your practice is wide open. You can innovate, you can create. We're going to share best practices with you all the time. We're going to be continually present, but we're going to encourage adaptation and change and so forth, so that quality becomes a pull process where the highest level of achievement keeps going up and up and up rather than a push process. In healthcare, we think healthcare safety and quality is a push process. Here's the best practice, and we push everyone towards that standard, and we use guilt, shame, and harassment as our primary tools to get there. That doesn't work well if you start with a broken thing to start with, right? Why would we want to put in place best practices that are frozen in this year? It's ridiculous. So, completely different approach to pull systems, to quality, and how we actually manage the entire system. We want to create usable platforms that scale to tens of thousands of people, population health and community wellness. That's what we're trying to get to. In order to do that, we need to eliminate parallel wasteful systems. So we put all of our eggs in one bucket. We do whole person, whole family, whole system approaches. We eliminated almost completely disease-specific approaches and retooled specialty stuff. So we have behavioral health, pharmacists, HIV, pain, and social work incorporated right into the primary care practice. So these are highly, highly capable, deeply capable primary care teams in which the most common specialty things are put fully integrated into the practice, not some place that you refer people to. And the conversation becomes a story of both giving and receiving story longitudinally over time with people who know you on both sides. Because, by the way, we have to also rehumanize our entire workforce that have been dehumanized by their clinical and medical education. This whole thing of professional distance we think is ridiculous. We want professional proximity. We want messy human relationships because our goal is to influence people's thinking and choices. And as April showed you, it's much better. Our diabetes outcomes are in the top percentile, 1% for the entire United States of America. Most of our outcomes in the top 25th percentile in an extremely complicated high-risk population. On top of this, then we put a data mall, and we do population health using wellness platforms in the patient portal. We all can agree that electronic health records are pretty much terrible at this point. We're on the Cerner platform, but most of our activity is increasingly in the patient portal, wellness platform, and population health platforms that float above the EHR and are fed by the EHR. It's a very different thing than just being mad at the EHR all the time for not doing what you want it to do. Our data mall is locally created by us. We have 5 full-time data mongers who do nothing but create this stuff for us to be usable and actionable and so forth. So how do we get to the people on the wellness care plans? We use this complicated, very impressive data mall data system, because if you're going to do a tight, loose, tight, complex adaptive system, that means there aren't many rules and regulations, there's not much policing. It's continual conversation all the time, and it means that you have to know what's going on even more than you do in a regulated, rules-based approach. And so we do tons and tons of sophisticated things, from run charts to control charts to individual data to action lists. That's all fed right into the immediate environment, both for the customer owner and the people doing the services. And it helps us identify complexity that isn't just diagnosis-based, which helps us get then to the people who most need the most intensive companionship model, which is what April will spend a few minutes on here in just a second. So using data to identify complexity and risk, thinking household and community, not thinking disease specific, but rather all the dimensions go into affecting whether a person can or can't cope with all the complexities in their health journey. Then we put it into the messy human process of a relational complex adaptive system type approach. And the answers that come out end up being almost entirely around companionship, coaching, advising, and being present, and only very secondarily diagnosis, pills, procedures, and that sort of thing. In our system, we order far less MRIs and CTs and labs and pharmaceuticals. We're very expensive in human capital, but our total cost is 2/3 the national average in terms of total cost. We've shifted money to people, relationship, interaction, story, and decreased MRI, CT, lab, pharmacy, X-ray, specialty, and hospitalization. Oh, 2 data slides.
Yes.
These are people on wellness care plans, the blue bar being the people on wellness care plans, and the red bar being people not. So dramatically better diabetic control once people go on these wellness care plans. And these are screening numbers, so dramatically better, like 90th percentile performance on pretty much all screening plans. And these are the hardest to reach, most difficult, most challenging, high complexity individuals.
So that is the really big picture. Now my job is to say, okay, what is a wellness care plan in real life, and how does it happen? And I'll first say, we began many years ago by noticing that there were people using our system where by their utilization we could tell that these families were struggling, right? And we all have those people in our systems, and we thought, what can we do about it? And we began with a primary care focus, and we tried, and we failed, and we tried and we learned, and we tried and we made it better, and we're still trying. So our story today has shown data and success, but our journey is a journey, and we're still on it. And we're learning as we go. And our biggest lesson learned was that if we're going to think about how we wrap services around and partner with our most complex patients, it has to be from a whole systems perspective rather than just a very narrow perspective. And we'll talk about what that means. First, so we talk about tight, loose, tight. Tight, what is our philosophy? Really holding firm in saying our goal is to improve outcomes for these individuals and for these families. And a lot of systems have processes for high utilizers that look at utilization and cost and visits, and we try to avoid all of that and say, how do we know what it would look like for this person or this family to feel like they were accomplishing their goals? What are their goals? And how can we measure how we move toward that? And what we found out was, oh, by the way, when you start hitting those targets, you end up decreasing utilizations, hospital visits, ER visits, and cost in your system as an after effect. Requires lots of infrastructure. So Doug talked about our data platform and data systems. We actually have algorithms that tell our primary care teams for the population that they serve, what are the touches that those people have in our system. And so each of our primary care teams will have a list in the data mall, so actionable information in front of them that says who is using the system with the most of these negative touches. And when we talk to our primary care teams, they say, I already knew that about those people. because they're in relationship with them. And then we don't mandate that because someone's on a list, that means they need a wellness care plan. We simply use it as information so that those primary care teams can be in the loose environment of figuring out how, in their relationship with those people, they might work toward different outcomes, wellness care plan being one tool. Other thing I'll mention is this isn't a physician-driven process. Really, anybody on that integrated care team might say, you know what, we probably need to get together and have communication about what the goals are and develop a wellness care plan. Wellness care planning starts with a conversation between the behaviorist and the customer owner. And remember, this isn't a stranger who's reaching out to you to say, hey, I'm noticing lots of visits. This is the person who's been in relationship with you and your family over time. So I'm really proud to say that my son, who is now 10 years old, never knows not having a behaviorist as part of his integrated care team. And I can give examples of times when we've come in for something like a strep throat, and he said, Mom, can we talk to the BHC while we're there? What do you want to talk to the BHC about? And he'll tell me what he wants to talk to the BHC about. So he knows this person, he's in a relationship. Behavioral health exists as part of what people have access to. So that behaviorist and that customer spend time talking. And this is not a 15-minute visit. This is an hour or an hour and a half, depends on the situation. And the goal of that meeting is for that behaviorist to understand what the goals are for that customer owner and to have in their mind the goals for the customer owner and what we as a system thought were the outcome goals, right? And to somehow come to a shared vision of what this wellness care plan is going to be about. And then to come back to the primary care team and say, well, you thought this was the goal, but after we had story and conversation, we realized these are really the goals. So new shared vision of what that wellness care plan can look like. Concretely, we document that wellness care plan in the EHR. We have case conferences where everyone who might have a touch with that customer owner, everywhere in their system that they use. So it could be a traditional healer, an acupuncturist, a physical therapist, an exercise specialist, a surgeon, whoever is part of the care that's being delivered could be invited to do this case conferencing. And we've learned a lot. So my last slide is about kind of what are our lessons learned. I always like to say we stumbled along the way. Where did we stumble? First is we needed to get specific about action items that were part of the wellness care plan. So what were the specific deliverables, timelines, measurements that would help us know whether we were moving forward as we'd planned? So having those action lists in our EHR and deliverable to our integrated care team so that the RN or the CMA, whoever on the team makes sense to monitor them, can watch to see if we're actually accomplishing that care plan or if we need to regroup and replan if we're not. Early in the process, we did what we hate doing and we catch ourselves doing and we remind ourselves not to, which is we were being prescriptive about the process. And we learned, as we always do, back up on being prescriptive about process, be strong in philosophy. Let the teams figure out process, because those teams are in relationship with families. And it's not going to look exactly the same if we're going to work together, or if we're going to work together, or if we're going to work together, and we need to allow that flexibility. Third is working as an entire system. And fourth is we spend way more investment on developing the capacity of our workforce for being in relationship and co-creating vision with our customer owners. And this took even more of that. So lots of intentional training for our workforce. So what I want to end with is we give talks on lots of things that we do in our system. Today's talk was specifically about complex customers and wellness care plans. But all of that rests upon a system that is customer-owned, customer-driven, where customer voice is loudest and first. I'm a customer owner, and I'm loud. It's driven with an organization where the key is relationships. So we already have those relationships upon which you can do something like wellness care planning. And the last thing I'll say is that we believe that how healthcare looks today is not how it will need to look for my kids when they grow up. It's not how it's going to need to look for my grandchildren when they grow up. So one of the core competencies of our system is how we continually listen to our customer owners, ask them what they want out of a system, try to work to meet those needs, and give them a platform to judge whether or not we are compliant with meeting what they've set out for us to do. Thank you very much.